Assalamu alaikum wa rahmatullahi wa barakatuh. Welcome everyone. Thank you for joining us for today's webinar. My name is Tamer Ahmed, Academic Affairs Department. Before we get started, if you have any questions during the presentation, please type them into the question box. Our talk today will be about a state-of-the-art lecture in hypertension. Our speaker, Dr. Abdulaziz Zaidi, consultant, interventional cardiologist, Saudi German Hospital, Riyadh, past director cath lab at Prince Sultan Cardiac Center in Riyadh, past clinical assistant professor at King Saud University College of Medicine, Canadian Fellowship in Interventional Cardiology, German Board in Internal Medicine Cardiologist. تفضل دكتور عبد العزيز.
Thank you very much, Mr. Thamer. Our lecture today, our talk is about hypertension. The objectives is the stages of hypertension, treatment of hypertension, what is resistant hypertension, what are the secondary causes of hypertension, what is malignant hypertension. We'll go over these objectives one by one. The first one is stages of hypertension. The blood pressure 120/80 or less is an optimal blood pressure. However, nowadays elevated blood pressure considered systolic 120 to 129/80. The stages comes, number one, stage one is when the blood pressure systolic 130 to 139 or diastolic 80 to 89, and the hypertension stage two will be blood pressure systolic 140 more than 140 over diastolic more than 90. It's very important to remember that both systolic and diastolic hypertension independently will increase the risk of myocardial infarction or stroke, regardless of hypertension definition, whether the definition of hypertension is systolic 140/90 millimeter mercury, or the definition, the new definition, which is considered hypertension if the systolic 130 or more over the diastolic 80 or more. There are some patients that come to you in the clinic and they say, doctor, at home, my blood pressure is normal. When I come here to the hospital, it rises. Blood pressure will be 130 to 150 systolic over 80 to 90 diastolic. At this stage, it's reasonable to screen for what's so-called white coat hypertension. White coat hypertension consists about 20 to 30% of patients with hypertension. What do you do to rule out white coat hypertension? We usually do 24 hours ambulatory blood pressure monitoring. If that gives us normal blood pressure values, the patient has no hypertension. If the blood pressure values are high, the patient will be diagnosed with hypertension. This is a home monitoring. There are two types for this kind of evaluation or diagnosis: 6-hour test and 24 hours test. Usually we use the 6-hour test for exclusion of white coat hypertension. However, the 24-hour test is used to assess for nocturnal hypertension or discrepancy between home and office blood pressure, as we mentioned, or when you have evidence of target organ damage despite normal office blood pressure measurements. So the values or the measurements of ambulatory blood pressure monitoring considered normal if you have in the office blood pressure less than 130/80, and the ambulatory blood pressure monitoring gives you the same, less than 130/80, with nighttime blood pressure dip of at least 10 to 20%. However, if you have a blood pressure of 130/80 in the office with normal ambulatory blood pressure monitoring system, that is white coat hypertension. There is another phenomena called masked hypertension, which is the opposite of the white coat, i.e. in the office, the blood pressure will be 130/80, whereas the reading will be high in the ambulatory blood pressure monitoring. So this is the masked hypertension. If you have both office and ambulatory blood pressure high, this is called sustained hypertension. And the last entity is the nocturnal hypertension. This is during sleep when you have your blood pressure more than 120/70. This is considered nocturnal hypertension, even though daytime this will be considered obviously normal blood pressure values. So what does the guidelines tell us? There are a lot of guidelines. The clinical practice guidelines from 2017, mainly from the American College of Cardiology and the American Heart Association, tell us that if you have optimal blood pressure, which means, as we mentioned, less than 120/80, then we promote optimal lifestyle, i.e. to continue with optimal lifestyle. However, if you have elevated blood pressure, which is the value 120 to 129 systolic over 80, again, lifestyle and reassess in 3 to 6 months. The confusion comes between stage 1 and stage 2. If you have hypertension stage 1, which we mentioned, 130 to 139 systolic over 80 to 89 diastolic, then you have to consider the clinical ASCVD, which is the atherosclerotic cardiovascular disease risk. If it's more than 10% for the next 10 years, if the answer is no, then you continue with the lifestyle and reassess in 3 to 6 months. However, if it's yes, then you do lifestyle also, but you should start hypertension medications. Whereas obviously in the hypertension stage 2, which is systolic more than 140, diastolic more than 90, you do lifestyle, and of course you have to start hypertension medications. So in the evaluation of hypertension, the first step is to exclude white coat hypertension. The second step is to use the ASCVD risk to guide medication threshold for hypertension. If the patient is known cardiovascular disease, then we are talking about secondary prevention. And if the blood pressure more than 130/80, you start medication plus, of course, lifestyle modification. If the ASCVD 10 years risk more than 10%, this is considered now primary prevention. And if the blood pressure is more than 130/80, again, you start medication with lifestyle modification. Then step 3, which is use of the ASCVD risk estimate to guide medication threshold for hypertension. If you have the ASCVD, excuse me, this is a mistake here, 10 years risk less than 10%, then we're talking about primary prevention. Only if blood pressure more than 140/90, not 130/80, only if blood pressure more than 140/90, then you use medication and lifestyle modification. What about patients more than 79 years old? As we know, the American College of Cardiology and American Heart Association pooled equations are validated for US adults aged 40 to 79 years. Excuse me. So adults more than 79 years old, the 10 years ASCVD risk is already generally more than 10%. So if the systolic blood pressure threshold for medications in more than 79 years old patient is 130 millimeter mercury. Now let's talk about treatment of hypertension. Why do we treat hypertension? The benefits of hypertension treatments, it does decrease the stroke 35 to 40%. It decreased the heart failure more than 50%, and it decreased the myocardial infarction 20 to 25%. The first thing we should do is lifestyle changes. Lifestyle changes. It does decrease systolic blood pressure. Just by weight loss, if you lose 1 kilogram weight loss, you will decrease the blood pressure 1 millimeter mercury. DASH eating plan also decreased by 11 millimeter, dietary sodium reduction by 2 to 8, physical activity 4 to 9 millimeter mercury, moderate alcohol use, avoid NSAID. Sources of dietary sodium, mostly from processed food, 55%. Eating out, that's about 35%. And the table salt consists only about 10% contribution to the source of dietary sodium. Hypertension medications. As you know, there are many medications available, whether it's a beta blocker, whether it's a calcium blocker, and whether it's ACE inhibitors, etc., and ARBs and diuretics. But the question, which blood pressure medication to use? Usually, if the blood pressure more than 20/10 systolic over diastolic from the goal, then you should use probably at least 2 medications to control it. The initial medications, whether it's alone or in combination, depends on the patients. If the general population, including diabetes, usually you should start with low dose of thiazide with any of the other antihypertensive medication, whether that calcium channel blockers or ACE inhibitor or ARBs. For Black patients, the same thing, you start with thiazide, but you should start with calcium channel blocker, even if they are diabetics, unless they have chronic kidney disease. The second step will be ACE inhibitors or ARB. For chronic kidney disease, especially the patients with more than 300 milligram per day albuminuria, then you start with ACE inhibitor or ARBs. How about pregnancy potential, recent MI or systolic congestive heart failure, stable coronary disease? Again, for pregnancy, the choice alone or in combination, calcium blocker with beta blocker. For the recent MI or systolic congestive heart failure, the beta blocker with ACE inhibitor. Stable coronary disease, as we know, ACE inhibitors and beta blocker or calcium blockers. As you know, there are special populations with hypertension, such as diabetes, sleep apnea, pregnancy, and blood pressure lowering in type 2 diabetes mellitus does have benefits. And in meta-analysis, it does have benefits in mortality, and congestive heart failure, stroke, heart failure, retinopathy, albuminuria. Now let's switch gear to the resistant hypertension. What is the definition of resistant hypertension? There's at least the JNC7 definition and the American Heart Association scientific statement definition. The JNC7 definition is blood pressure more than, when you have a patient with a blood pressure more than 140/90, compliant with 3 drugs, including diuretic, and all drugs at or near maximum dose, and still the blood pressure obviously high, which is 140/90. This is considered resistant hypertension. Whereas the definition of the American Heart Association is, again, uncontrolled blood pressure despite 3 drugs, or even blood pressure controlled but requires at least 4 drugs. and they call it controlled resistant hypertension. We should be careful when we label a patient with resistant hypertension, because 50% of uncontrolled blood pressure is due to so-called pseudo-resistant hypertension, which means either improper blood pressure measurements or white coat effect or poor medication compliance, which happens in approximately 30% of the patients. Half is a true resistant hypertension. So what are the causes? The causes of resistant hypertension: excess sodium intake, inadequate diuretic therapy, medication dose or side effects, and secondary cause of hypertension. What is medication side effects which cause hypertension? Such as patients who are taking NSAID or COX inhibitors, patients taking oral contraceptives, sympathomimetic, decongestant, diet pills, stimulants, amphetamines, antidepressant, erythropoietin, cyclosporin, even herbal compounds can increase blood pressure. There's also so-called refractory hypertension. Again, the definition of refractory hypertension is inadequately controlled blood pressure despite 5 or more medications, including diuretics. This occurs in approximately 3% of resistant hypertension cases. So refractory hypertension occurs in 3% of resistant hypertension cases. As we mentioned before, lifestyle intervention for resistant hypertension is very important. Sodium intake less than 1.1 gram per day in patients with uncontrolled hypertension on 3 drugs can lower the blood pressure by 23/9 millimeter mercury. Exercise, which is treadmill, walking 3 times per week for 8 weeks, can reduce the blood pressure by 6/3 millimeter mercury. So how do we treat resistant hypertension? There are the so-called 3 steps. You start with the diuretics, such as chlorothalidone, 12.5 to 25 milligram daily. Then you have a choice of ACE inhibitors or ARB in combination with long-acting calcium channel blocker, preferably twice daily to maximize the effect. Then spironolactone or eplerenone, 12.5 to 50, centrally acting alpha-beta antagonists such as labetalol, centrally acting alpha-2 agonists, or vasodilator such as minoxidil plus loop diuretic. So again, there's 3 steps. First step is to optimize diuretics. You have thiazide, thiazide-like loop diuretics. And we should know that chlorothalidone is twice as potent as hydrochlorothiazide. And also we should remember, as you know, that thiazide and thiazide-like meds can cause dyslipidemia. Step 2, optimize ACE or ARB and calcium blockers. ACE and calcium channel blockers superior to ACE inhibitor and thiazide alone. Also, ARB and calcium channel blockers control blood pressure in 60% of individuals in prior 3-drug regimen, including diuretics. Third is mineralocorticoid antagonist, spironolactone or elebrenone. Of course, we have to be careful in patients with eGFR more than 30 ml per minute per 1.72 meters square. And we should remember that Hyperkalemia risk increased with patients with chronic kidney disease, especially an ACE inhibitors, ARBs, and NSAID. Also, breast tenderness and gynecomastia is a dose dependent, of course, especially for spironolactone. Now let's talk about secondary causes of hypertension. Secondary causes for new or uncontrolled hypertension is about 10%. And we should suspect it in drug-resistant or drug-induced hypertension, abrupt onset, hypertension onset in a patient less than 30 years old, accelerated or malignant hypertension, onset of diastolic hypertension in adults more than 65, diastolic hypertension, or unprovoked or excessive hypokalemia. In all these patients, we should screen for secondary hypertension. This is a class 1 indication. Again, resistant hypertension due to secondary cause from sleep apnea, which is made 25 to 50%, primary hyperaldosteronism in 8 to 20%, and renal artery stenosis 5 to 34%. This is the main 3 causes of secondary causes. Other 3 is less common, which is renal parenchymal disease, drug-induced or alcohol, and pheochromocytoma. So what are the screening tests for secondary hypertension? As you know, hypohyperthyroidism, pheochromocytoma, primary hyperaldosteronism, Cushing disease, renal artery stenosis, and sleep apnea. It's worth mentioning that renovascular disease, usually 80 to 90% atherosclerotic renal artery stenosis, especially in men more than 50 years old, and usually it affects the proximal 1/3 of the renal artery. Whereas fibromuscular dysplasia is most common in women less than 30 years old and affect the distal 2/3 of the renal artery with media involvement. Now let's talk about malignant hypertension. What is malignant hypertension? It's a systolic blood pressure more than 180 millimeter mercury and or diastolic blood pressure more than 120 millimeter mercury. And we should look for symptoms or signs of end organ dysfunction. If there's no symptoms or signs of end organ dysfunction, this is hypertensive urgency. However, if there are symptoms or signs of end organ dysfunction, this is labeled hypertensive emergency. What are the clinical findings in hypertensive emergency? Chest pain, usually from ischemia or dissection, acute pulmonary edema, dyspnea, neurologic deficit, cerebral infarction, or encephalopathy. What is hypertensive urgency? Hypertensive urgency is severely elevated blood pressure, more than 180/120, however, without progressive end organ dysfunction, and usually due to under controlled hypertension. Whereas hypertensive emergency, it's usually severely elevated blood pressure, more than 180/20 millimeter mercury, with progressive target organ dysfunction, and this requires emergent lowering of blood pressure. Clinical scenarios such as hypertensive encephalopathy or acute congestive heart failure with pulmonary edema, acute myocardial infarction or unstable angina pectoris, or dissecting aortic aneurysm. How do you treat hypertensive emergency? We should look if it's non-stroke. If it's non-stroke, hypertensive emergency, There are the possibility for acute aortic dissection. In that case, you should lower the systolic blood pressure less than 120 millimeter mercury in the first hour. If it's eclampsia or pheochromocytoma, you should lower the systolic blood pressure to less than 140 millimeter mercury in the first hour. Whereas all other hypertension emergencies, you should first lower the systolic blood pressure by 20%, 25% of maximum blood pressure presentation in the first hour, then decrease to 160/100 over the next 2 to 6 hours. Then you decrease it to normal over the next 24 to 48 hours. However, if it's acute intracerebral hemorrhage, and it's less than 6 hours from ICH symptoms, then if the systolic blood pressure is 150 to 220 millimeter mercury, the systolic, then it's really harm if the blood pressure goes below 140 millimeter mercury. Whereas if the systolic blood pressure more than 220 millimeter mercury, then we should start lowering the blood pressure with IV medications. Now, acute ischemic stroke. How do you manage the patients with acute ischemic stroke with hypertension? If this stroke less than 72 hours from CVA symptoms, then the question is, does the patient qualify for IV thrombolytics? If the answer is yes, then you should lower the blood pressure to less than 185/110 before lytics, and then try to maintain the blood pressure below 185/110 for the first 24 hours. If he does not qualify for IV thrombolytic and the blood pressure is less than 220/110, then no blood pressure lowering for 48 to 72 hours. Whereas if the blood pressure is more than 220/110, then you should lower the blood pressure at least 15% within 24 hours. This is a very busy slide. It's mainly for the vasodilators that you would use in hypertensive emergencies. I'm sure you're familiar with most of these drugs and their doses. Only consideration, you should watch out for reflex tachy and avoid glaucoma for the phenyldibam. And for nicardipine, you should watch for reflex tachycardia and avoid an acute congestive heart failure or MI. For the scenarios, most hypertension emergency, you will use them, plus beta blocker if dissection. For the nitroprusside, avoid if acute myocardial infarction or coronary disease or elevated ICB or renal impairment. And for nitroglycerin, the only thing you consider is the reflex tachycardia, and the best scenario is acute MI or congestive heart failure. Again, for enalaprilat, you avoid an acute MI, but the scenario will be for acute congestive heart failure. There's also adrenergic inhibitors for hypertensive emergency, again, such as labetalol, esmolol, metoprolol. Again, consideration, you should watch for heart block and avoid an acute decompensated congestive heart failure. So we covered the treatment indications for hypertension, how lifestyle modification and medication strategy for hypertension is very important. And we define resistant hypertension and how do you approach it therapy-wise. And we talked about secondary causes of hypertension, which is very important. And then finally, we talked about, we covered the treatment of hypertensive urgency and emergency. Thank you very much.
Thank you so much, Dr. Abdelaziz, for the nice presentation. Now we can go for question and answer, please.
Okay. So there are a lot of questions. Of course, I do not have a chance to go over them or see them, but I will scan them very quickly. And the ones I cannot answer now for the time, I will try to send the answer to the colleague who are asking the questions. So let me see what we have here. Okay. Actually, most of our comments here. Most of the question you can answer. They are asking if it's CME hours, asking for
yes,
presentations.
there is medical questions, Dr. Abdulaziz, you can find.
What about uncontrolled hypertension? How will patients take it? There's a question, what about uncontrolled hypertension with patients taking medications? We talked about this and we define what's resistant, what refractory. So you have to go with the 3-step, what we talked about. Mainly start with the diuretics, and then you have a choice between ACE or ARBs or calcium blockers. Then mainly patients with elevated and stage 1/2 medication. Mainly patients with elevated and stage 1/2 medication. Again, for the blood pressure medications, like I mentioned, most patients will require more than 2 medications, but sometimes you can control it with 1 medication. The issue here is that you don't want to give 1 medication and just go up with the dose to the maximum, because sometimes you run into side effects. So to minimize the side effects, it's better to have combination, two drug combination, to avoid side effects. The same question again here, saying my question is how to avoid the side effects of antihypertensive meds, especially with all generations. So I guess I answered that question already, that don't give full dose of the medication, start with low dose, and then if it doesn't help, my suggestion is to go to a second medication with low dose and go up carefully. This way you can really, you can avoid most of the side effects of the antihypertensive medication. Okay. A lot of comments which Tamer can answer later on. Okay. Okay, thank you very much. I think we covered the most important questions here.
Thank you so much, Dr. Abdulaziz. Thank you, everyone. Next webinar will be, inshallah, coming Saturday at the same time, 9 p.m. For any communication, you can communicate with me, please, on my WhatsApp. My number is 0502-466-292. The certificate will be sent after 3 days from today. Thank you so much. Assalamu alaikum wa rahmatullahi wa barakatuh.
Thank you.